Our fourth case for today is a 62-year-old male who is a known case of hypertension and diabetes who presented with chief complaints of effort angina.
Hello,
Yes, we can hear you.
am I
Yeah.
am I audible?
Yes, very much. Yeah.
Hello?
Yes, we can. Can
Yeah,
you
yeah,
hear
yeah,
us?
fine.
Yeah.
And have you seen the case?
We just were going through the history.
Yeah,
so
please go ahead.
Yeah, please go on.
History.
Yeah. He presented to us with the chief complaints of effort angina. His 2D echo showed normal LV function, LVEF 60%. Coronary angiogram showed CAD double vessel disease. PCI to ramus lesion was done before 3 months. His syntax score is 14. Our plan is to do image guided PCI of complex LAD and diagonal lesions.
So, just see the angio. It's a bad lesion. Ramus has already been fixed before. Yeah. Right? And see LAD diagonal.
Is it a CTO, the LED?
We don't know. Yeah, it could be.
Yeah. In this view,
Yeah.
it's a non-dominant, right?
And there's a lot of calcium I can see on fluoroscopy.
It looks like the disease in the LED extends all the way to the
And
ostium.
there is a diagonal which is probably recently occluded and it is almost like parallel LAD.
Yes. Some distal left main tapering also.
Yeah. This is a 7 French EBU guide and this is a opposite end of the stiff wire. I am trying to unfold it with that.
Can we see the live screen?
Are they showing?
Now we are on the,
It is unfolded. I don't want to put it in the left LV in this case. So, yeah, we are in.
that's in.
Fluid आपो भाई.
The plan is upfront a two-stent strategy or single stent?
Fluid आपो. LV normal. Okay.
The plan is upfront two-stent strategy or single
No,
stent?
I am not sure about that. Go to AP caudal, we will decide. And this is again a bad negatively remodeled artery and I will like to be a bit minimalistic here. I am not sure. Ramus result is fine. Yeah, go to aleocranial, we will take a long view. I am not going to touch that OM at this point of time. My focus will be on LAD to start with. Samir?
Yes.
What
it's-
do you think about the wire choice? Stark and our Indian guest Lakshman Das. I think Ajay is also there, right? Or not?
Can we do, is it better seen in a steep areocranial or something?
Areocranial. Just take areocranial.
Like in a 30 or 35 plus cranial.
Areocranial.
I think you will take run through extra floppy with reuri only.
Oh yes, this I am very happy now. Get me run through. My focus will be at this point of time only on LAD. Because if you make a good LAD, patient survives and patient lives a good life.
Yeah, I agree. I
that's-
think the LED can easily go down at the diagonal. Still not see quite well here. So your choice wise of run through at this moment with a microcatheter or with a balloon or a microcatheter with a CTOY.
As usual, I'll try simply with this and then we will see. It may not be a CTO, I'm not sure.
I think my prediction is the run through probably will not go, but we'll see.
Go to AP caudal. Run through with Riuri 1.5 has 99% chance to enter. Let us see.
We'll see.
Scout.
It's good, yeah. We'll,
Okay, go to areocranial.
yeah. You're almost there. You're proving me wrong already.
Scout. out. Now get me Riuri 1.5. Get me Riuri 1.5. Get me Riuri 1. Oh, I mean, fine.
Yes, you're in.
Perfect.
All right. Awesome.
Get me now
Name of the Riuri.
2 millimeter.
Name of the Riuri is also important.
That was awesome.
I am happy. Yes. સંજય આજે બપોરનું તું થાકે નહીં તો સંભાળી લે છે જેટલું થાય એટલું ચાલ એક ઇન્જેક્ટ કરી લો Again, Professor, this is an extremely negatively remodeled artery. What do you think of Avtandil? Huh? Bad artery. Proximal also is diffuse and everything. Yeah, let us see. So now, my contemplation is, there is a good chance that I may not even touch diagonal. See, any new cardiologist or any new fellow who comes in this lab, it has been our traditional teaching from me and Sanjay, what is most important. And the answers we receive is, you have to be careful, you have to learn step by step, this, that, everything. But then, the most important thing they don't know, and I'm teaching them every time. Correct me if I am wrong. Patient has come alive in the cath lab and patient should go out of the cath lab alive. That should be the first and foremost requirement.
That is true. That is true. It's okay to not win.
Yeah. See? Okay, fine. With a moderate sort of jackhammering, I could deflate. It's a 2 by 15 Riuri.
Seems like a very nice balloon.
Yeah, the Riuri is super.
Yeah. What do we have in the United States? No, I mean, what's the name of the balloon? It's not Ranjan, but it's...
Deflate. Now,
It has grown, actually.
so now how many of the people in the panel is for diagonal and how many are not?
I'll prefer to just have touched the diagonal try with a run through extra floppy with a Riuri
Yeah.
only.
The only issue is it Ajay?
Yes.
Ajay, the only issue is the ostium of the diagonal is not good. So if you try and if you open it up, you see that. Then you have to go for a mini crush or something, and the artery is not, 2.25 to 2.5, somewhere in between. And that sort of metal crowding, I personally feel in long run, it may not be good. And this is again a extremely ischemically preconditioned diagonal. Avtandil, what do you think? Professor Patwari, what do you think?
Yeah, I think we should escape. And diagonal is small, the diffuse disease, and I cannot clearly see the distal bed, the distal branches. So
Yeah.
I think
So should we do OCT or IVAS? I think OCT, Professor?
OCT. I
Yeah.
think the OCT is
OCT.
a good tool in this case.
I have taken 7 French guide, keeping this thing in mind that if we need to use 2-stand strategy, we are comfortable. You can see Avtandil distal in the mid part also, there is a long disease segment. I will like to see, I think we need to tackle that too. What do you think?
We
Panel?
should assess the mid segment.
Yeah.
No, it is a diffuse disease.
Yes,
You're going
yes.
to find a very safe, healthy landing zone, maybe it will
Yeah.
be challenging.
Yes.
So you have to almost like till the mid portion, you may end up in stenting, actually.
I think the OCT will tell us
Yeah.
what to do. Go back to the diagonal,
myocardial breach?
right, TJ? I think some study indicated if we want to treat the diagonal, we need evidence, at least a
Look like a disease
10%
one.
of the myocardium.
Myocardial bridge is there.
And the Korea
There is there.
study said that
Probably
if you
one-sided,
have 2.5 vessel
bridge is
and
there.
more than 78 millimeter
exposed
length,
all around
you're
it.
worth to treat the diagonal.
The lumen is quite enough for clearing the vessel lumen for OCT, or we need
No,
the
this
light
is a
lumen?
good lumen for
Good
OCT.
lumen.
My question to you, Samir, you are practicing interventional cardiology since decades in US. I am not asking you about the newer, like this old generation of Indian diaspora, because they almost have the same South Asian pattern. But those who have born and brought up over there, and young guys who are coming to you with MI, what is the coronary artery disease profile and pattern in those Indian or Bangladeshi or Sri Lankan diaspora?
So second generation, South Asian presenting with MI, right? Is that what you're asking?
Yeah.
So I personally, anecdotally, have yet to see a second generation Indian come with an MI.
Oh, really?
Yeah, so, and I think partly it's because their lifestyle is much more healthy compared to the first generation. They're very choosy about what they eat, they exercise, they have a different mindset, so they're not always
But that's a
stressed.
pleasant surprise, huh?
Yeah. Now, in South African and English research cohorts, I think there is data on that. I don't know the results of it, but and from what I gather from the superficial view is
Survey?
that it's the same as first generation. Rajiv, do you have any recollection of second generation UK diaspora, Indian diaspora in UK?
Yeah, but things have changed even in the last 10 or 15 years. 15 years ago, it was quite similar to this, but it was dominantly
Nothing.
in smokers.
It's not moving.
Now I have the same experience as you, Sam, that the current generation is different.
It came
I think
out
smoking
very
has
late.
played absence of smoking has played a
मैं
big
नहीं
role.
कहूँ any
Yeah, I think this is a lot of interest in the acculturation of the South Asian or Asian America living in the United States also. South Asian actually is not that bad compared to Southeast Asian. For example, Filipino, they have worse acculturation effect. There are more patients smoking, hypertension, obesity. Very interesting.
Yeah. No. Yeah.
Yeah, Dr. Kwan just wrote the consensus document on Asian coronary disease for American Heart Association. So his insights are probably the latest.
Something?
Yes.
It was a significant grip, and we had to turn over to the manual pullback. But it's not all that bad. But you can see the small arteries.
Yeah.
They don't look very good.
Very tight stenosis, right? But here.
Yeah. That is the mid segment.
Yeah.
It's a bad disease.
Yes.
Fibrotic and healed plaque, right?
Yes.
So one question I have is, even though the OCT's lens moves inside a plastic sheath, why does it have resistance in a diffusely diseased artery? It's actually protected from the wall because it's moving inside a plastic tube, right?
Yeah, my logical explanation for this, Samir, is if there are calcific nodules here and there, at least it will create an angle at that point of time in the tube, and that may give, sort of a resistance in that region.
The angulation is the only explanation, right? Yeah.
Okay. So, Professor, what do you think?
Yeah. Very tight lesion, right? So we need a further dilatation.
So 2 millimeter LED?
Yeah. Here might be media to difficult to measure right around here.
2.25?
2.5. Yes, ballooning.
Low pressure. Yeah.
Right.
You want to dilate in the middle part? It's okay.
Vessel is 2.25, right? But maybe shrinkage.
2.5.
2.5, yes.
2.5 by 38.
Yeah.
Synergy.
Right. Okay. And the calcium is very spotty and very short. And yeah, try to measure the length, right?
And we don't see the EEL in most of the vessel, right?
Yeah.
Yeah.
EL is around 2.25 to 2.5, right?
Okay.
Okay.
So, would you then quarter size down?
But here is an shrinkage, right?
Okay.
Okay. If we will have enough flow,
Yeah.
it may become a little bit bigger,
Yeah.
right?
And there is not much of the calcium. It is a predominantly
Yeah.
fibrotic
Fibrotic,
hill plaque.
yes.
Yes. So no problem.
Right.
Yeah. So, Dr. Akasak, a quick question for you. How many times do you see a large difference by giving nitrates before, the OCT size before and after nitro? Do you see a very large difference, or is it all hypothetical?
It depends, but yeah, in this case, the flow is very important, right? If we have a big flow, the distal may dilate based on the shear stress. But at the moment, we cannot get any good flow. Therefore, the distal vessel should be a shrink, right?
Right. So giving nitro will probably not make a difference here,
No,
right?
in this case, not too much.
Sure.
What about using a stance like R0, which is having a strut thickness about 80 or 81, rather than having a thickness of a higher? Will it make, because in a lumen like this one, will it make a lot of difference in the outcome?
Here is a bifurcation, and we can identify the positive remodeling, right? Just proximal of the LAD here, right?
Right. Now, that's the circumflex bifurcation, right?
Right.
8.
Because then is your guide after that, right there.
Deflect.
Okay, right.
That's left main, I think.
Yes.
The left main looks good actually compared to angiographically.
Yeah, very good.
Yeah, I was worried about the distal left main, but there is not much going on.
Yeah.
That is the left main overall is the only place which has not been negatively remodeled. Everything else.
Yes. So that's a 2.5 stent.
Yes.
Did not look that oversized, so it looks good. Looks good, size-wise.
View. Okay. You see, this is again negative, but this is not a negative. This is, yes. This is probably the artery has lost the tone because of the chronic deprivation.
Probably, yeah.
Yeah. Go on 2 or 3. No problem. Go on 2 or 3.
And Tejas, in these type of situations, low pressure, you don't see dissections.
No.
Even if it's
up
diffused.
to 4, 5, 6 atmosphere, nothing happens. Deflate.
Even if
this is balloonomics. I learnt it from Fayad Sol way back. Right. Although people didn't believe what he said, but he used to make a lot of sense when he spoke. And he said that the balloon will conform to the artery size till when you inflate up to 5 or 6 or nominal, pressure. And you can use a even 4 millimeter balloon. It will also not over expand. If the artery is 3, it will remain 3. Yeah. Deflect.
Yeah.
But here in this case, it may or may not. But this mechanical dilatation is going to help us. Let us see. Check it out now. Look at this. There is a tapering. Another deceiving thing. Fortunately, there is no distal dissection. However, that's the reason why I was thinking of 2.25. But here it was showing 2.5.
I think the distal, like you predict, is going to grow. Tomorrow it will be looking
there's
like
a
much
possibility.
better.
Yeah.
As long as we don't see a hematoma or anything at the landing, it'll be all right.
And now go to AP caudal, and I like to see the proximal length. Yeah. Professor, what do you think? I will make sure that I am not protruding outside. Maybe one strut is all right. No problem.
Yes, I agree. Yes, here is the bifurcation, right?
Proximal LAD.
Yes. And here bifurcation. Then just the proximal. We have a positive remodeling and huge fibrous plaque and small spotty calcium, right? So 1 or 2 strat comes in, it's okay because LCX is enough big and no disease.
Absolutely.
Right?
What length would you take?
Yeah, I will take the wire back and see. Wait. Wait, yeah. 1 minute, 1 minute, yeah. Go ahead. 28? No, Sanjay. 24 should be fine. What do you think? And whatever, the imaging shows, I think this should be fine with 3 by 24. What do you think?
24, yes.
Again,
3 by 24.
What was the size of the very proximal area between 50 and 60 marker?
Yeah, he will tell you, Professor.
Right.
Law.
3 by 24 cylinder.
Difficult to see the completely, but here is just proximal site, and I try to measure about. This might be the media, right?
Yeah, that looks like the EEL probably, right?
Maybe around here, right?
Wow.
4.25.
Wow.
So it's a very positive remodeling here.
So, what do you think? What should be the size?
Yeah, 3 should be okay. And
Samir, what will you use? Tak, what will you use?
I think
and
3.
Let me ask my
3
Indian
may be
friends.
okay.
I think since the previous stent was 2.5, based on that, I think this is 3.0.
Yeah,
I would go by pure angiographic sizing.
Go to LAO caudal. And if I have to protrude the struts a little bit and cover the ostium, my go-to view is LAO caudal, nothing else.
Correct.
So, Dr. Akasaka, another question for you.
Yes.
When do you not believe intracoronary imaging sizing? What are the, if you can give 2 instances, assuming that you see EEL.
Right. Yeah, for example, in this image, you can see this portion, right?
Right.
Here is in the calcium and the fibrous, but we cannot identify any external lamina, right? At that time, it might be very difficult to identify, to decide the size of the stent. Anyway, we try to find some portion to measure or speculate the size. Here, you can identify the media, right? Yeah, so here to here might be around 3.3, right?
This is fine. This is perfect.
In this case, 3 should be okay,
Sanjay, go,
right?
Until you agree.
Because if we decide the media to media, quarter size smaller, right? Therefore, in this portion, I think 3 might be okay. And also, we have a 2.5 around here, right?
Right.
Yeah. So might be safe.
And does the lack of circular, contour and measuring it in the longest possible dimension bother you? Or would you take an average of the long and the short, or what would you do? Oh, we can't hear you, I think. Okay.
Just before the big branch, the size is very similar, right? After big branch, size suddenly change.
It drops.
Therefore, we try to check the branch and also the size, right?
Right.
Yeah.
Apuja?
Thank you.
Samir, let me ask one question to Professor Akasaka about the angiocore registration tool. How useful is it? And should we have in all cath labs, especially for long diffuse disease?
Yeah, I completely agree with his comment, right?
OCT
registration gives us a lot of information based on the branch position, right? So it is quite easy to identify the place. The landing zone, yes.
Absolutely. It's so much more precise.
Yeah. And
at least with OCT, we inject contrast so we can see the eye moving. With IVUS, it's very difficult to not co-register.
Yes, that's right.
do you think there's from vessel sizing, iris and OCT is similar or
No.
they're different?
No. OCT overestimates the vessel size by at least 7% at IVUS as compared to OCT.
Yeah, IVUS is always bigger.
Bigger, yeah.
Yes.
Yeah,
7 to 8%, as the Dr. Patel said. Yes.
There's good phantom data from Dr. Akasaka's lab.
Yes.
Yeah.
I think everything original coming from OCT, 90% of it is from him.
Yeah. But the iris nowadays is a 60 hertz. You think it's the same, similar to 40 hertz, the sizing?
Yeah, from CRF report, they said the very similar, right? But
Wow.
we are not sure. Yeah, right.
Now you guys see one shot Sanjay gave to take care of everything. That is 38 plus 24. Almost 72 in a survey mode, and it's a clean image, first shot. Absolutely white, completely.
Yeah, that injection technique is a clear winner, I think.
Yeah, very wonderful position and very symmetric.
Yeah.
Great.
Yes, can you then afterwards show the fly-through image to the young guys?
Yeah. So the distal expansion is very good. The proximal is saying 63%.
No, it is because it is taking reference of left main, Samir. At the ostium, when you deploy the stent, just ignore that finding.
Okay. Yeah, but we can right from the.
Simply ignore that finding because it is taking reference of left main.
Right. The position.
Look at this. Look at this.
Yeah, position is wonderful, right?
Yeah, the landing is perfect.
Yeah. Here is an CX and the bifurcation.
So just show the fly-through view to the young guys.
Okay, right.
See, this view does not help much to the clinician, very rarely. But it is very important to show the patient and the patient relatives to understand what we have done.
Right. You can identify the CX in the 9 o'clock, right?
Yeah.
And stent start just proximal of the LAD, right?
And that is a big well. That is
yes. Great. Yeah.
No, it looks nice. Would you expand the proximal stent anymore?
No. Never.
Yep.
What do you think? No. Yeah.
Perfect.
Look at this.
Yeah, great.
It's a pick-to-pick design. You can see that. At least from these, you can, all these, even the OCT images, you can identify whether the stent is a Zions design or non-Zions design.
Yeah.
Because Zions is only peak-to-valley design. Every other stent is peak-to-peak with different areas of link.
Okay, let's explain the distal portion, right? There are no disease, I think.
Can we see the diagonal origin?
Diagonal origin just show, in any case, it was simply the way it was before.
Wait a moment.
It is buried in the two layers of the stent, I suppose. Yeah, just show the angio.
We cannot see. Here might be the diagonal,
just at the
right?
proximal end of the two layers.
Yeah, here might be.
Little more
This one, right?
Okay.
All right. Okay.
Okay. So I think if you guys don't mind, we can conclude our live demo session here. We can disperse for the lunch, and I will request all the attendees to attend the afternoon session. Specifically, we have kept it because there are some great talks, and some young guys have requested us because they get time in the Sunday afternoon, they want to come to listen. So maybe instead of 2 o'clock, we can start at 2:15, the last session where there will be some great didactics. So I thank you all, my international guests, my national guest faculty friends, as well as the participants for being patient during these 1.5 days of live demonstration. Thank you.
Awesome performance. Great cases. Thank you.
Thank you.
Excellent.
That's it. Areo cordal le lo last view. So we are concluding live. Unbelievable. Mr. Mudaliar, we landed up with great result. Oh. Thank you. Thank you. Thank you.